जी रब इशरह ली सदरी व यस्सिर ली अमरी वहलुल उक़दतम मिन लिसानी यफ़क़हू क़ौली। एरिथमियास का टॉपिक हमने पीछे स्किप कर दिया था, आज हम वो पढ़ेंगे। एरिथमियास जो हैं ये फॉर यूएसएमएली स्टेप 1, इसमें से कुछ एरिथमियास जो इम्पोर्टेंट हैं, बाकी नॉट वेरी हैवीली टेस्टेड इन एग्जाम। लेकिन हाँ, कुछ एरिथमियास मैं आपको बताऊंगा वो बहुत इंपॉर्टेंट, वो आपको शुड बी एबल टू रिकॉग्नाइज दोस। बाकी आई वुड से कि दे आर नॉट अमंग द टॉप प्रायोरिटी थिंग्स, लेकिन जो मैं बताऊंगा वो आपने ज़रूर करने हैं। तो लेट्स स्टार्ट विद tachyarrhythmias। क्या? नैरो कॉम्प्लेक्स टैकीकार्डियास। जो नॉर्मल ईवीसी है ना, लाइक दिस इज पी क्यू आर एस एंड टी। ये क्यू आर एस होता है ना, इसकी नॉर्मल लेंथ होती है 120 मिलीसेकेंड्स। ठीक है। ऑन ईसीजी वन स्मॉल बॉक्स रिप्रेजेंट्स 40 मिलीसेकेंड्स, यानी QRS should not be more than 3 boxes. If it is less than 3 boxes, then it is a narrow complex. If it is more than 3 boxes, then it is a wide QRS complex. Okay. तो अब इसमें हो गया क्या? नैरो कॉम्प्लेक्स टैकीकार्डियास, द प्रॉब्लम लाइज अबव द वेंट्रिकल्स। ठीक है। आपको पता है कि these are the ventricles, and then you've got the atria, you've got the SA, you've got the AV, bundle of His, and the bundle of branches. ठीक है। The problem lies above the ventricles. Either the problem is in the SA node or the AV node, जिसकी वजह से ये नैरो कॉम्प्लेक्स टैकीकार्डियाज हो रही हैं। इसीलिए इनको हम सुप्रा वेंट्रिकुलर एरिथमियाज भी कहते हैं। सुप्रा मीन अबव, ventricular mean above the ventricles. So the problem either lies in the within or above AV node, could be the SA node. That's why these are called supraventricular tachyarrhythmias, supraventricular arrhythmias, or supraventricular tachycardias. अब एग्जाम पॉइंट ऑफ व्यू से the most important arrhythmia is this first one, जो आपको स्क्रीन पे नजर आ रहा है, which is atrial fibrillation. Atrial fibrillation के लिए the important buzzword that you would see in the exam, the scenario, that would be the character of actually the rhythm of the pulse, that is irregular. ठीक है। both in its timing में भी irregular, and also its volume, the pulse, it be irregular. तो हो सकता है आपको सिनेरियो में वो ये ना बताए, और शायद आपको ईसीजी ना दे, या आपको ये नहीं बताएगा, ही कैन टेल यू द पल्स रिदम ये कैसी है। तो बाय असेसिंग द पल्स रिदम यू कैन टेल दैट दिस हैज टू बी एट्रियल फिब्रिलेशन, और इट कुड बी मेट्रिफोर्कुलेटेड टैकीकार्डिया, उसको भी हम देखेंगे। इट हैज अ सिमिलर pulse character, pulse rhythm. ठीक है। So how would you recognize it on an ECG? For that, let me open the whiteboard. See, अगर normal ECG draw करूँ मैं, with something like this: P, QRS, and T. P, QRS, and T. P, QRS, T. P, QRS, and T. So you can see that the RR interval, this is the RR interval. RR interval, or in other simple words, the distance between the QRS complexes, it is roughly equal. ठीक है, this is equal. This is normal. ठीक है. Now what happens in atrial fibrillation? In atrial fibrillation, Let's discuss the normal thing. Normally, the SA node, it has a character that is automatic. It has automaticity. खुद ही discharge होता है after a specific time. ऐसे से pulse निकलती है, reaches the AV node. इतनी देर में atrial contraction होती है. In AV node, there's a delay, and then pulse is transmitted to the ventricles. This is normal. Atrial fibrillation, the atria is discharging rapidly, like wildly. Atria is being stimulated. There is some abnormal point which is continuously exciting the atria. Or atria bar usme, it is not contracting properly. It is fibrillating. It's just vibrating. Now, AV node, आपको पता है, AV node has a refractive period. it will receive a pulse. It will receive a signal from SA node, and then it will take some rest, and then it's going to transmit it. Then it's going to go into refractive period, and while in which it's going to recharge itself. All the ions, वो सारा sodium potassium को अपना balance करेगा. That is its refractive period, and it's in its refractive period it cannot transmit any pulses, any impulses, electrical impulses. अब ऐसे in atrial fibrillation, the atria they are discharging wildly. वो बार बार impulse generate कर रहे. अब AV node, since AV node has a limitation, वो हर impulse को respond नहीं करेगा. वो सिर्फ उस impulse को respond करेगा जब वो खुद, when it's out of its refractive period. So this is the reason. So AV, so you can be asked in the exam, what is the reason of the irregular character, irregular rhythm, or what is the reason of what limits the rate of this tachycardia? So we'll say that the refractive period of AV node is actually the limitation here, because the impulse would only be transmitted if the AV node is out of its refractive period. So now let's see what's happening on the ECG. So this was normal. PQRST, PQRST. let me label it. PQRST. Okay. Now observe this ECG. So here you can see the obvious difference. First of all, the RR interval is not equal. Like this RR is small, this is large, this is then small, this is smaller, this is even smaller, then this is large, this is very large. So RR interval is not equal. One thing. Second thing is that you cannot appreciate a P wave. There are no distinguished P waves. Instead of P waves, you're getting these vibrations, these zigzag pattern, small vibrations. So this is how you'll be able to recognize atrial fibrillation. Irregular in rhythm without any P waves. So this is how an atrial fibrillation looks on ECG. ठीक है? अब what's the cause? The common cause of atrial fibrillation is old age. बूढ़े लोगों के अंदर 70s, 80s, there is a very likelihood you would find atrial fibrillation in these people. ठीक है, बूढ़े लोगों के अंदर. And the other pathological cause is valvular heart disease. ठीक है, in which the atria gets enlarged. Yes, Dr. Mamshad, you're correct. So in mitral stenosis, the atria, they get enlarged. ठीक है, so in atrial enlargement, it promotes development of atrial fibrillation. तो उसके अंदर आपको atrial fibrillation मिल जाएगा. तो ये ऐसी पैथोलॉजीज के आपका अंदर आपको atrial fibrillation. The other important causes जो आपको एग्जाम में आएंगी, there is massive intake of binge drinking, alcohol. इसलिए the funny name for atrial fibrillation is also holiday heart syndrome. West में ये culture ज़्यादा है. People on their weekends, they drink a lot and they end up in the hospitals telling to their physician that कहते हैं कि जी we're having this funny feeling in our chest. हमें दिल की धड़कन महसूस हो रही है. we are getting palpitations. So this is an important cause. Another very important cause, rather of an endocrine region, that is hyperthyroidism, especially in Graves' disease. There is a very high chance that you would get atrial fibrillation in those patients. ठीक है, तो एंडोक्राइन कॉज एक आपको बता दी, एक आपको ये मेटाबॉलिक कॉज बताई मैंने, इस अल्कोहल intake, acute. ठीक है, acute binge drinking alcohol can cause atrial fibrillation. Now ये तो होगी causes and all the pathophysiology of atrial fibrillation. Its complications are important. You see, atria normally contracts, sends blood into the ventricles. एक important valvular heart disease, जैसे मैंने बताया, mitral stenosis. You see, in mitral stenosis, there is already obstruction for the blood to flow from atria to the ventricles. तो ये लफ्ज लिख लें. You write it down in the section of valvular heart disease of mitral stenosis, that mitral stenosis is worsened if it is accompanied by atrial fibrillation. क्योंकि mitral stenosis, you see, in normal heart, the first 2/3 of diastole, the blood flow from atria to ventricle is passive. And in the last 1/3, the atria contract and send the blood. Mitral stenosis के patient में, there is already less blood flow, okay, because of the obstruction. And it is mostly relying on the atrial contraction in the end part of diastole, so that the atrial contraction forces the blood through that stenos valve to send blood into the ventricles. And now if this patient develops atrial fibrillation, that contraction, he would lose this contraction, because atrial fibrillation ka patient, his atria is just vibrating, it's not contracting. So उसमें it will be worsen, because atria से blood आएगा ही नहीं ventricles में. The end diastolic volume would be so low that would ultimately result in low stroke volume and low cardiac output. तो patient जो है वो, he can go into syncope, he can go into heart failure, he can die. So this is one complication. The other important complication is, and the one that is more frequently tested in your exams, वो है clot formation, intramural clot formation. आप में से जिन लोगों ने जनरल पैथोलॉजी पढ़ी हुई है, you must have read of the term Virchow triad. क्या आप वैसे मुझे कोई बता सकता है Virchow triad क्या होता है? It is something related to clotting. 3 things that promote clot formation. Yes. One is hypercoagulable state. Other is endothelial damage, as Dr. Zainab आपने ठीक बताया. And third is abnormal blood flow. ठीक है. Now this third factor is responsible for clot formation in a patient of atrial fibrillation. क्योंकि उसके एट्रिया के अंदर ब्लड, his atria is not pumping blood into the ventricles. His atria is just vibrating at a place. The blood over there, blood has chance to stay, to get steady. And wherever the blood gets steady, there starts clot formation. तो उसके एट्रिया के अंदर क्लॉट बनना शुरू हो जाएगा. ठीक है. That is why in patients of atrial fibrillation we often give we give heparin वगैरह देते हैं उनको, anti-clot. We give drugs that inhibit clot formation, okay, so that they, so we अगर clot बन गया, for example, that clot, that thrombus that can dislodge, that intramural thrombus can dislodge and become an emboli. Or wo emboli, you see, it's going to escape from the atria, it's going to enter the ventricles, and from left ventricle is going to go into the aorta, and from aorta it can go anywhere in the body. If it enters the brain, it will cause stroke. ये पेशेंट मैंने देखा हुआ अपनी इमरजेंसी के अंदर. He presented with hemiplegia, an altered state of consciousness, and our teacher over there, he examined the pulse, and he also told us to examine the pulse. We examined the pulse, and the character was irregular. And our teacher told us that there is a very high chance that the reason for stroke in this patient was an intramural thrombi, which again was due to atrial fibrillation. So again, it's the correlate CNS के साथ इस तरह से बनता है. There are other places in which the clot can stuck and cause ischemia. An important place is superior mesenteric artery. Your superior mesenteric artery supplying the small gut mostly, and parts of the large gut as well. तो वहां पे जब लॉज हो गया, it will cause intestinal ischemia. It will cause ischemic bowel. Patient कैसे आएगा? Patient will come with severe pain in abdomen, severe pain, acute, or he would say that on examination, his abdomen, his or her abdomen would be very hard, just like a table, rock hard, because of the reflex contraction of the abdomen. The body thinks it is in danger, and the abdomen gets stiff. क्यों? क्योंकि the clot has dislodged into it's stuck in the superior mesenteric, and distal to the clot, there is ischemia or ischemia में. The other complaint patient is going to say that he is having clots of blood in his stool. So such a character of stool is called current jelly stool. Okay? You can also get current jelly stool in interception, because in interception the cause is the same. There's ischemia and interception as well. So यहाँ भी ischemia है, वहाँ भी ischemia. In both, the patient will complain of he'll say that he's having chunks of clotted blood in his stools. उसको हम कहते हैं current jelly. So this can also be, so this is how this AFib can be correlated with GIT. इसी तरह से, if a patient, let me give you a scenario. There's a patient who has a known history of hypothyroidism. Okay. And she comes to the hospital, to the physician, and she complains of funny feeling in her chest. What would you think? क्या हो सकता है? इसको hypothyroidism है, इसको funny feeling आ रही है, and you examine the pulse, and she's having atrial fibrillation. तो क्या वजह? Yes, Dr. Sanna, आपने ठीक बताया. She is likely taking high doses of thyroxine, so her dose needs to be adjusted. तो इस तरह से भी presentation हो सकती है. तो these are the scenarios that you can get, which can be connected with atrial fibrillation. I think this is it. And let's go back, read first aid. And how to treat it. Treatment at your level, it's not important. You don't need to know the treatment. Just remember in mind, कि अगर patient है, you need to give him anticoagulants if you diagnose a patient AFib. वैसे इसकी ट्रीटमेंट की पूरी एक regime है, एक पूरा algorithm है, which is more of a step 2 thing. You don't need to know about that. But just for the sake of interest, I'm telling, उसमें basically हम कहते if a patient comes in he has AFib, अगर तो उसकी history हो 2-3 days की, 2 days 48 hours की, then um, we resynchronize the rhythm. ठीक है? We actually give him a shock. Shock ना दो तरह का होता है. One is called defibrillating and other is called resynchronization. So we resynchronize his heart to correct the rhythm. And if the history is longer history is other lambi history, then we first make sure that there's no clot in the atria. We do some transesophageal echocardiography to make sure he doesn't have a clot. So again, this is step 2 thing. You don't need to think about it a lot. अच्छा जी, coming back to first aid. अच्छा जी, क्या लिखा है इधर? Irregular rhythm, no discrete P waves, originates from automatic foci near pulmonary vein ostia in left atrium. So this is an important thing. This is the left atrium and these are openings of pulmonary veins. So जो normal, abnormal जो points होते हैं which keep on discharging, they are near these ostia. Yeah. Common risk include hypertension, coronary artery disease, may predispose to thromboembolic events, particularly stroke. Can also mention ischemic bowel. ठीक है, ischemic bowel. So management कैसे करेंगे? You control the rate and rhythm. Cardioversion. This was I was talking about. कि आप shock देते हैं, a synchronized shock. ठीक है? And the definitive treatment, the absolute, the cure is we use a cautery and we burn and we ablate these foci so that they don't discharge. The treatment is ablation of pulmonary vein ostia. So ablation near the pulmonary vein ostia where there is the abnormal foci. And consider anticoagulation based on stroke risk. Okay? This was all about atrial fibrillation. Atrial fibrillation सबसे the important topic है पूरे arrhythmias के. Next है MAT, multifocal atrial tachycardia. Now let me show you how it looks in an ECG and what's the pathophysiology going here. You see, MAT, you'd find MAT in patients of COPD, and especially when their O2 saturation drops. MAT का क्या मतलब है? Multifocal atrial tachy. मल्टी मतलब बहुत ज्यादा, फोकाई मतलब फोकसेस जो डिस्चार्ज कर रहे हैं. तो इन पेशेंट का जो एट्रिया होते हैं ना, पेशेंट सीओपीडी, यहाँ डिफरेंट फोकसेस होते हैं. When the O2 saturation drops, these foci develop ischemia and they start to discharge. वो बार बार discharge होते हैं. तो on ECG you're gonna get, मैं ECG ड्रॉ करता हूँ. So again, you can see that the RR interval is not equal. Again, the rhythm is irregular. But the important thing is P wave देखें, observe the P wave, especially the morphology. ये P wave देखें, फिर ये P wave देखें, फिर ये P wave, ये P wave, this, than this. So if you are getting irregular rhythm with P wave of more than 3 morphologies, different shakal ki P waves, then this is a multifocal atrial tachycardia. And what's the treatment? You just correct the O2 saturation. You put the patient on oxygen, and this ischemia will be gone, and the rhythm will become normal. Okay? So this is about MAT, multifocal atrial tachycardia. Irregular rhythm, at least 3 distinct P wave morphologies due to multiple ectopifoci in atria, associated with conditions as COPD, pneumonia, heart failure. Okay? Then there's atrial flutter. Atrial flutter, the main characteristic thing on ECG is this zigzag pattern, which is called sawtooth appearance. So this important thing. होता है इसमें पता क्या है? If this is the atria and normal atria and SA node, this is the SA, this is the AV. The impulse they travel to AV node and then into the ventricles. इसके अंदर पता क्या होता है? Instead of the impulse should finish over here, the impulse instead start to travel in circles inside the atria. And it travels so fast and fast and fast and fast that the atria they start to flutter. Okay? So the heart rate can even become very high, like 200 to 300 beats. This can be the rate of atrial flutter. Okay? There is re-entry circuit around tricuspid annulus, right atrium. Yeah, again, the treatment is treated like AFib. You give anticoagulants, vagara ye wo. But the definitive treatment, you do catheter ablation of the region where there is this re-entry circuit, which is the tricuspid annulus and IVC. ये region पता है कहाँ होता है? देखिए, this is the right atrium. This is the inferior vena cava opening, and this is the tricuspid. So the tricuspid annulus, it is somewhere over here. This is the region where you want to do the ablation. Okay. Next, PSVT, paroxysmal supraventricular tachycardia. This is also called SVT. Okay. In ECG, you would get narrow complex QRS, and the RR interval would be normal. It would be equal, but the rate would be very high. अब इसके अंदर पता क्या होता है? There is a re-entrant track between atria and ventricles, commonly in AV node. Now let me explain this on the whiteboard. Yeah. You see, this is the SA and this is the AV. अब मैं AV node and impulses, they travel from here to here in a normal person, and from here down into the bundle of his in the ventricles. अब मैंने इसको zoom in करने लगा. I'm going to be zooming this section. Yeah. And this is an enlarged portion of the AV. ठीक है? अब AV के अंदर ना basically this ye impulse are here, for example. This is the impulse coming. Now impulse has got two ways to go. Two pathways. One is a slow pathway and other is the fast pathway. This is the fast pathway. This is the slow pathway. अब होगा क्या कि impulse enters here, slow pathway में, and before it reaches into in the end, fast pathway से impulse जल्दी से travel करेगी and it will be transmitted into the ventricles. ठीक है, ये normal हो गया, and this impulse will be cancelled out क्योंकि ये already पहुंच गई थी यहाँ पे. Now, one important thing about the two pathways is that the slow pathway, it has a small refractive period. Matlab it is ready to transmit new impulses, whereas the fast pathway, it takes time. It has a longer refractive period. ठीक है, अब जैसे हमने देखा कि यहां से impulse गुजर गई थी. Now this part is in its refractive period, whereas this path is ready. The next impulse is going to come here. It's going to travel the slow part, and when it reaches this point, tab tak the refractive period, this part is refractive. The impulse can't go here because this part is in refractive period. But once the slow impulse reaches here, this part would be ready to excite. Refractive period khatam ho jayega, and the impulse will enter here and it's gonna move back. It's gonna circle. और जब तक ये यहाँ पहुंचेगी, this part would be, now this part would be ready to excite again. ठीक है, so this way there's gonna be this circling of impulse. The impulse is gonna keep circling in the AV node. तो इसको कहते हैं re-entrant pathway. So this is what happens in, this is one of the mechanisms by which supraventricular tachycardia occurs. ठीक है, so this is just for the sake of understanding the concept. There's a slow pathway, a fast pathway. Slow pathway का refractive period कम है, fast का pathway ज़्यादा है. तो इससे ये impulse यहाँ पे it circles again and again and it keeps transmitting to the ventricles as well. इसलिए on ECG you get narrow complex tachy. This is what you get on SVT. ठीक है, अब थोड़ी सी बात करते हैं इसकी ट्रीटमेंट की. How are you going to treat it? Very simple. अगर तो पेशेंट यंग है, then you do vagal maneuvers that excite the vagal nerve, or vagal nerve inhibits the SA nodal AV nodal firing. It blocks this SA AV conduction. So what you can do is you can do carotid massage in young. ठीक है, you do not do carotid massage in elderly population, for people who are elderly, because in elderly population there is a chance that they might have atherosclerotic plaque in their carotid. तो आप carotid massage करेंगे, उससे वो plaque आगे चला जाएगा, brain में stroke करवा देगा. लेकिन if the patient is young, you can do carotid massage, क्योंकि carotid massage करने से vagal nerve stimulate होती है and it helps decrease the heart rate. So this is one of the maneuvers you can do. Other maneuvers include Valsalva maneuver. You ask the patient to strain. तो उससे क्या होता है कि again there's vagal reflex and it helps bring down the heart rate. And if these maneuvers are not working, then you can give antiarrhythmics, you can give calcineural blockers, verapamil, diltiazem, or you can give beta blockers. Okay, this is about SVT. अच्छा, I have SVT में एक और important बात देखें, heart is contracting very fast rate. The heart does not get enough time to refill. वो जब से सही से refill नहीं करेगा during his diastole, then the stroke volume would be decreased. So the body, the brain would not be receiving appropriate amounts of blood, and the person would feel dizzy. उसको चक्कर आएंगे, वो बेहोश हो सकता है, या हो सकता है वो बिल्कुल नॉर्मल बैठा हो. So there's a spectrum of clinical picture. मैंने ऐसे पेशेंट भी देखे हैं जो ऐसे ही बैठे हुए हैं, लाइक उनको एसवीटी हो रहे हैं, दे लाइक दे जस्ट चिलिंग, दे फील नथिंग. फिर मैंने ऐसे पेशेंट देखे हैं वैसे हमें दिल की धड़कन बहुत तेज हो रही है, घबराहट हो रही है, दे फील एंग्शियस. Then there is a category as well who become unconscious because their blood pressure drops and they become hemodynamically unstable. So in these patients, we immediately have to do cardioversion. We give them shock, a resynchronization shock, ताकि उनका SVT खत्म हो जाए. So if the patient is hemodynamically unstable, you just don't wait for the vagal maneuver or the drugs. You right away give the shock. Okay. So now let's read about this here. Most often, re-entrant tract between atria and ventricles, most commonly in the AV node, as I just explained, presents with sudden onset palpitation, lightheadedness, diaphoresis. Okay? Treatment. Terminate the re-entrant rhythm by slowing AV node. That can be done by vagal maneuvers. And you can also give IV adenosine. We will talk about this in greater detail in the pharmacology portion. Electrical cardioversion if hemodynamically unstable. Okay? And the definitive treatment again is ablation of the re-entry tract. ठीक है, तो इस तरह से आपने, this is how you're going to treat the patient. Next important arrhythmia. अच्छा, ये जो है ना, इसको PSVT भी कहते हैं. PSVT, paroxysmal, because होता पता क्या है? It starts out of nowhere and it ends immediately, like after some time. खुद ही शुरू होता है, खुद ही बंद हो जाता है. तो that is all PSVT. अगला जो arrhythmia है, that is Wolff-Parkinson-White syndrome. And which congenital heart disease did we study is associated with Wolff-Parkinson-White syndrome? Can anyone tell me? Yes, Dr. Javia, you're right. Epstein anomaly. इसमें क्या होता है? Now again, let me share the whiteboard. You see, there's AV node, AV, sorry, SC node, AV node. The intranodal pathways. Yeah, the normal pathways, bundle of S, and the bundle branches, and the Purkinje fibers. This is normal. In Wolff-Parkinson-White syndrome, there is an extra route from SA to AV. This is an extra track. And it's faster. तो इसमें normally अब ECG आनी चाहिए थी. Normally you see you get P wave, and then there's a break, and then you get QRS and T. This break is due to the SA and AV, the delay. Lekin in a person with this extra track, atria से ventricle के दरमियान extra track, which is faster. So it would depolarize the ventricles faster. Okay, and a mistake I made over here. Let me correct it. the extra pathways between the atria and the ventricles, not the SA and AV, between the, let me draw a line. This is the line between atria and ventricles. An extra pathway between atria and ventricles. अब क्या होगा? अब let me draw it with red. अब P wave, or now since there is no AV nodal delay, तो क्या होगा? This delay would be absent. Instead, QRS यहीं से शुरू हो जाएगा. क्योंकि अब डिले नहीं है, अब एक एक्स्ट्रा पाथवे जो ज्यादा तेज है, impulse would directly into the ventricles and you would get this slurring of the wave, and this is called delta wave. ठीक है? So if you get a delta wave, and you can also see the QRS has become broad. यहाँ पे इतना था and is big. So broad QRS with delta wave, this indicates Wolff-Parkinson-White syndrome. ठीक है? और एक बहुत 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 important thing, do not treat WPW with beta blockers or calcium channel blockers, because what they will do, beta blockers and calcium channel blockers, they will decrease the SA and AV pathway. They will decrease the conduction here. And the conduction to this pathway is now going to increase even more. And it will actually worsen the Wolff-Parkinson-White syndrome. So these beta blockers and calcium blockers, they are contraindicated. Do not give them in a person with Wolff-Parkinson-White syndrome. ठीक है? Well, let's see what's written over here. Most common type of ventricular pre-excitation syndrome, normal fast pathway. Accessory pathway is called bundle of Kent, जो मैंने draw किया था. Bypasses the rate slowing AV node. Ventricles depolarize earlier, and characteristic delta waves produced with widened QRS complex, shortened PR interval. Okay, this can, Wolff-Parkinson-White can lead to re-entry circuit, can cause supraventricular tachycardia. Treatment, procainamide. ठीक है, procainamide दें, and avoid AV nodal blocking drugs, which are beta blockers and calcium channel blockers. Next are wide complex tachycardias, okay, in which the QRS would be more than 120. Okay, here the tachycardia originates below AV. So you can also, theoretically, you can also call them infraventricular tachycardias or infraatrial tachycardias. Like, just to remember it, we don't name them like that. Hub, here there is VT, ventricular tachycardia. Simple. क्या होगा कि broad QRS complex, and there is a focus in the ventricles that is exciting it. So most commonly due to sexual heart disease, cardiomyopathy, risk of sudden death. Okay. Next is torsades. Torsades the point is, इसके अंदर क्या होगा? Torsades में, the characteristic is that you get rising and falling wave in ECG. जैसे यहाँ नजर आ रही है. Rise and then fall. So this pattern indicates that there is torsade points. This occurs in polymorphic ventricular tachycardia. Polymorphic मानी ventricle के अंदर different foci हैं which discharge and they are causing VT. ठीक है, there's a shifting sinusoidal waveforms as seen here. Can progress to VFib. This can convert into something like this, VFib, which is again deadly. fatal. So ये drugs से होता है. So you need to remember, you need to be able to recognize any drugs in the history of the patient, drug history. Antiarrhythmics class 1A, class 3, antibiotics, especially macrolides, fluoroquinolones, antipsychotics, haloperidol, chloroquine, antidepressants, TCAs, diuretics, thiazide, emetic, antiemetics, antifungal, fluconazole. तो ये drugs आपको पता होनी चाहिए. These can cause torsades de pointes. Because all of these drugs, they cause QT prolongation. ठीक है? So QT prolongation can lead to torsades de pointes. Then there is ventricular fibrillation, also called VFib. VFib में the ECG makes no sense. It's just zigzag, not even proper zigzag, just simple doodling. It's just like that, as you can see here. ठीक है? तो VFib patient, in VFib में क्या होगा? Ventricle contract नहीं कर रहा है, instead is vibrating just like that, fibrillating. तो body को blood नहीं जाना, patient will immediately go unconscious, and you'll start to do CPR, and you give the patient shock. You defibrillate the patient so that the rhythm comes back. You keep on giving CPR and you defibrillate after every 2 minutes or so, I think. तो इस तरह करते हैं इसका treatment. And moving back now. Next है channel hereditopathies. ठीक है, इसमें क्या होगा? There is some abnormality in either the sodium channel or the potassium channel. ठीक है? These are of very little importance. Lekin if they do come, you should be able to recognize कि disease है. ठीक है? There is some problem in the cardiac ion channels. Now there are two types, Brugada syndrome and congenital long QT. In Brugada syndrome, the problem is with the sodium channels. ठीक है? Again, not very important, बस आपको ये पता हो in Brugada, this problem is with the sodium channels. Can present with pseudo right bundle branch block. Again, this is of step 2 level. Congenital prolonged QT syndrome is a further of two types, Romanov-Ward and Jervell-Lang-Nielsen. आपको पता है QT interval represents the portion where the heart is actually repolarizing, and repolarization of the heart, the potassium channels are responsible. तो इसके अंदर potassium channel खराब होगी इन दोनों के अंदर. How would you differentiate? First, this is autosomal dominant, this is recessive. दूसरा ये कि you would get deafness in Jervell-Lang-Nielsen syndrome. Lang-Nielsen में you get deafness. जबकि in Romanov-Ward there will be no deafness. तो ये फर्क है. Next important one is sick sinus syndrome. Sick sinus. Sick means not working properly. Sinus is the SA node. So this is age-related degeneration of SA node, where SA node stops giving up impulse. आपको पता है SA node is the control center. It's gonna give the P wave, then P wave is gonna be followed by QRS. SA से impulse आएगी, AV से आएगी ventricles में. अब इन पेशेंट्स के अंदर ये होगा कि कभी-कभी P QRST, and all of a sudden there is no P wave नहीं आएगी, then there's gonna be a gap. And the heart's gonna know that, oh, SA is not working. I need to take over. AB कहेगा कि oh, ऊपर से signal ही नहीं आ रहे. I need to do something. And then suddenly AB will shift. Now the control center, AB will control it. So there will be no P wave then. तो ये देखें ECG के ऊपर क्या हुआ. Very clear here. P QRST, and then there's a pause. And at this point, AB took over. So this is called escape, junctional escape. is called junctional escape. ठीक है, is a sinus pause, sinus arrest. ठीक है, escape. तो इसमें again bradycardia, because SA node not working, so you can get bradycardia. This is important, by the way. ये elderly population के अंदर आ सकते हैं. Then the conduction blocks, and conduction blocks मैं थोड़ा समझाता हूँ आपको. On ECG, they're very interesting. So let's start off with the normal ECG. P, QRS, T. P, QRS, T. P, QRS, T. This is normal. Okay? And one thing, in heart blocks, you focus on two things. First, primarily, is the PR interval. Second is the RR interval. Okay? Let's see. This is normal. Now let's draw a patient of, and let me measure the PR interval. PR interval is patient ka jo, which is this length. Should be able to know. This is the PR interval. Yeah, this is the PR interval, and this is the PR segment. See that there's a difference. PR interval begins with the PR, and normally it is 120 to 200 milliseconds. In other words, 3 to 5 small boxes on ECG. Now I'm going to draw another ECG. T, QRS, T, P, QRS, T, P, QRS, T. So यहाँ पे you can clearly observe that the PR interval is prolonged. लेकिन the rhythm is regular. The RR interval is regular. It's equal. RR is equal. ठीक है? This is first degree heart block. So in first degree, there is just PR prolongation, the PR interval that increases. Okay? And no treatment required. No treatment. Okay? Next, now I'm going to draw another ECG. और उसमें आपने मुझे बताना है क्या हो रहा है. So what do you observe here? Yes, Dr. Sana, आपने ठीक बताया. You see, PR interval, if you observe it, यहाँ पे it was this much, यहाँ पे इतना हुआ, यहाँ पे ये इतना हुआ, यहाँ पे ये इतना हुआ. And a time came when there is a dropped beat. Dropped beat. So if there is progressive PR interval prolongation, but by that I mean is PR The sequence goes like this: PR1, PR2, then PR3, then PR4. ठीक है? And again, the RR would be equal. So if you're getting such a condition, then this is second degree. But more specifically, this would be type 1 of secondary, also called Mobitz. Mobitz type 1. ठीक है? There is progressive prolongation of PR. अब एक और ECG बनाता हूं आपके सामने. Observe it. ECG is all about rhythm and symmetry. Bus. ECG is X-rays and CT scan. I believe these are all about symmetry, finding symmetry. If you find anything out of the pattern, then that's abnormal. This is the trick of all these X-rays and CTs and ECGs. What do you observe over here? Yes, there are misbeats over here and over here. Let's observe it in greater detail. देखिए, the PR interval here, that be equal. PR equal to PR. Again, and one more thing, you don't even need to treat type 1, Mobius type 1. No treatment required. PR interval will be equal, but you would find a specific pattern between P and QRS. You see, P, QRS, then P, then QRS, then P. So you get 3 Ps and 2 QRS. Similarly, again, P, QRS, P, QRS, P. So the pattern is 3:2. For every 3 P waves, you get 2 QRS complexes. One of the P wave is not being responded, not being conducted. So this is called, again, this is a secondary heart block, but this is Mopitz type 2. Okay? This can also be of different, and this does require treatment. Okay? This does require treatment. Now, मैं एक और ECG बनाता हूँ, and you recognize it. Try recognizing it. What do you see over here? What do you think? What do you think this is? The Dr. Sana says independent beating of atria. Rosanna, maybe that is because of my bad drawing, but I tried drawing another Mobis type 2. Yes, Dr. Javia, you're correct. This is Mobis type 2. Yes, Dr. Kurtan, you're also correct. This Mobis type 2, but now the ratio is different. Kya ratio? What's the P and QRS ratio in this ECG? You tell me. Let's count them. P, QRS, P, QRS, P, QRS. और डॉक्टर अहमद अली आपने बिल्कुल ठीक बताया. This is 4 P's with 3 QRS. ठीक है? So again, this is Mobis type 2. And the RR interval is equal here. And then there's a drop beat. A drop beats here. And the PR segment is also equal. So this is again Mobis type 2, but with this, and it needs treatment. You place a pacemaker. Okay. Or Sana, it is not type 3. I'm gonna draw a type 3 now, and you're gonna find the difference. Okay. आपको फर्क वाजे हो जाएगा. Okay, I should open it up on Google. That'd be better. My drawing is not that perfect. Just give me a moment, please. यहाँ दिया हुआ है, बल्कि it's here, it's present here. यहाँ पे आप देखें, this is 3rd-degree art block. So the two major differences here, कि the PR interval, there's gonna be no PR, I think PR, क्योंकि P would be beating with their beat, and that would be equal. जो P interval होगा ना, that be equal. P, 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 P. One thing. Other thing is the QRS complexes, they would also be at regular intervals. क्योंकि these are actually from AV node. A junctional rhythm है, which is around 60s or 50s. So there is complete disconnection between P and QRS. There's no link. Talaq ho gaya. They are completely separated, divorced. There's no relationship between these two guys anymore. ठीक है? तो जबकि यहाँ पे क्या था? यहाँ पे you had proper PR, which was equal to PR. There was a synchronization with P, QRST, P, QRST. And then you had a dropped beat. लेकिन यहाँ पे first thing, that there would be bradycardia, okay, and P interval would be equal, and R interval would be equal. And third thing, there would be no synchronization between P's and QRS. ठीक है, तो ये फर्क होता है. This is how you recognize the differentiate the two types. ठीक है, तो अब हम इसको रीड कर लेते हैं. First degree, there is just PR interval prolongation more than 200 milliseconds, benign and asymptomatic. Obvious type 1, Wenky back. Progressive lengthening PR interval until a beat is dropped. Variable RR interval with a pattern. It's regularly irregular. This is the pattern. Regularly irregular. And again, no treatment required. Obvious type 2. Drop beats are not preceded by a change in PR interval. And this can progress to third degree. And you give pacemaker. This is where the treatment starts. And उसके बाद क्या है? Third degree. Third degree में क्या मिलेगा? P and QRS complexes rhythmically dissociated. They have their own rhythms, which are regular, atrial and ventricle beat independent of each other. And here atrial rate is greater than ventricular rate. ठीक है? It's going to occur in Lyme disease. Treatment is pacemaker. And which wall myocardial infarction is usually associated with heart blocks? Any of you tell me. Yes, inferior wall MI is associated with heart blocks. You can also get heart blocks with some drug overdosing. For example, beta blockers, calcium channel blockers, especially the non-dihydropyridine type. Okay? Digoxin. So what's the treatment? Acute management. In acute management, you give atropine. Okay, remember, acute management of heart blocks, you give atropine. याद रखना है. Then there's bundle branch blocks. You see, मैंने आपको बताया था, we talked about these in the S2 splitting topic, that after the AV there is bundle of S and the right and left bundle branches. You don't need to know much about these. This is not tested in USMLE step 1. Is something related to step 2. Okay. Then the last topic is premature beats. If there is a rhythm and that rhythm is broken by a beat which is coming early in the time, that is a premature beat. Yeah. They could be atrial premature contractions or premature ventricular contractions. The difference between these is that a premature atrial contraction would start with a P wave, seen here, and it would be narrow. Whereas premature ventricular contraction would not be preceded by its P wave because it's originating in the ventricles, and it would be broad. Okay? This can occur in caffeine consumption. It can increase the risk of AFib, flutter. Premature ventricular contraction, ectopic beats arise in the ventricles. And the important thing about premature ventricular contraction is a stroke volume is decreased because the heart, in between the beats, the heart is in its diastolic period. It is filling. And if a beat comes prematurely, the heart fails to refill properly. So, and systolic and diastolic volume is decreased. And that actually decreases the stroke volume. ठीक है. So this was all about arrhythmias. ठीक है. तो think yes, we're done with arrhythmias. Now we're left with a few topics of patho, which include shock, tamponade, and we were done with endocarditis and traumatic fever. Syphilis heart disease is a small topic. We discussed much of this as an aneurysm and pericarditis, and we'll be done. Then we left with pharmacology. तो बाकी का जो है हम इंशाल्लाह will continue tomorrow. हो सकता है कि we might have to spend one more day on cardiovascular system. Might have to spend one Monday because it's because of my health condition. इलाज भी खराब है. I'm putting effort. So sorry for the inconvenience. Again, this is not in my control. Baki, any of you have any questions you can ask? Otherwise, we're gonna end this session here. Packs? Rasana, what do you mean by packs? PVC is testing exam. Yes, आपको ECG दी होगी, and you should recognize the pattern. उसमें देखेंगे आप there's a premature beat. So the concept that they usually test is that वो आपसे ये पूछेंगे कि why the stroke volume is less in this beat, and that is because of incomplete filling of the ventricles. Do you have to know the detailed mechanism of drugs that prolong QT interval? Mentioned torsades. देखिए जो drugs torsades में लिखी है ना, some of them are from chemo. उसमें से कुछ GIT में से हैं, कुछ CNS में से हैं, कुछ एंटीरिथमिक्स हैं. तो जो जो सिस्टम आप पढ़ेंगे वहां पे वो ड्रग्स की डिटेल भी आप पढ़ लेंगे खुद ही. ठीक है. बट यू शुड बी नोइंग कि उनका ये ड्रग्स करवा सकती हैं क्यूटी प्रोलोंगेशन. तो हाँ, आपको उनकी डिटेल पता होनी चाहिए अकॉर्डिंग टू दैट सिस्टम. ठीक है. तो सही है. इंशाल्लाह वी विल कंटिन्यू tomorrow. Thank you for your attention.